So first of all, good evening, one and all. On behalf of Navjivan Center for Development, I would like to welcome you all. And as today we are gathered to discuss, very important topic of mental health. And the title Dr. Anant Bhan sir has given is to address the treatment gap in the mental health, the role of primary healthcare embedded approach. And I think it is quite unique, the topic as far as the public health field is concerned. So those people who work in the healthcare sector, they definitely find some meaningful takeaway from these sessions. And before move ahead, I would like to introduce formally to Dr. Anand Bhan sir. So Dr. Anand Bhan is very noted personality, especially in the public health field, and sir is known as a global health researcher. And sir is also mentor and principal investigator at Sangath, Bhopal hub, and maybe the participants are aware about Sangath is very known, the organization with national repute. I think they have a headquarter at Goa. We may learn more from the Bhansar as well. So sir is especially trained medical doctor with a master degree in bioethics from the University of Toronto. Bhansar is adjunct visiting professor at Enopia University in India. Sir is also immediate past president of International Association of Bioethics. His work is focused on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community engagement, ethics of innovative technology, and the ethics training for the professional. Sir has been resource person or training in global health, research methodology, research ethics, and public health ethics, and also serve as a guest faculty in the various educational institutes in India and abroad. Sir is also reviewer of the multiple journals, conference of scientific committees, and the international grant competitions. Sir has also served as right now currently serving as a Bhopal hub, a lead for Sangath, is the principal investigation site PI for the various projects conducted at the Sangath Bhopal hub, funded by both international and national funder. Sir, I also know that you are also the member of the various government committees to give your inputs, especially in the policy making institutions or the policy level insight for making the or revising the various public health programs, especially in the central government and the various state governments. Sir, it is my honor and privilege to welcome you on behalf of Navjivan Center for Development and all the development sector community, those people who are here to listen and learn from you. Thank you once again, sir, for accepting our invite and giving your precious time to us. Now, without taking much time, I would kindly request you to proceed for the session, sir.
Thank you, Professor Sanjay, and thank you for that kind introduction. Hi, everyone. Good evening. A pleasure to be part of this discussion. I and Professor Sanjay have been in, exchanging emails, messages for quite a few weeks now, trying to figure out a time. So I'm glad that we have finally could zero in on today. And as Professor Sanjay said, the idea would be to discuss a little bit around mental health and how we could think of pathways to integrate mental health into primary care. So what I'll try to do is to maybe speak a little bit about Sangath, a little bit about the topic, and then also some of our own work in this space, and then maybe make some recommendations, which hopefully will lead to some discussion. We'll try to finish it maybe in an hour 15 minutes so that there is enough time for discussion as well. So I will share some slides just to get us started on the discussion, and then hopefully that will also illuminate some of the discussions. So as the topic says, we're going to talk about the treatment gap in mental health and the role of a primary healthcare embedded approach towards that. And hopefully this will tell us why this work is important and how it can be done. Now, many of you, I think, work in this space and would have an interest in primary care because that has a long history, as we all know. But specifically, also in terms of the organization, Sangath, as Professor Sanjay was saying, has been working for almost the last 27, 28 years now in the space of public health. Started off working in Goa in 1996 with a small clinic, and since then has expanded to almost a national footprint with work in many states and with major hubs in Bhopal, Pune, and Delhi. We work primarily in partnership with state governments. So our work is usually embedded within state health systems. And the idea is to try to come up with innovations which can influence primary care adoption, which can influence health systems, rather than doing innovations which will not likely to have any impact on the ground. And for this, we have received several national and international awards, and our work has been funded by multiple prestigious organizations such as Wellcome Trust, NIH, Medical Research Council, Grand Challenges Canada, MacArthur Foundation, and the Tata Trust, and other funders. Specifically, the team that I work with is the team in Bhopal, in Madhya Pradesh, and we started working in the state of MP in 2011 with an MOU with the Directorate of Health Services, Government of Madhya Pradesh. Our initial work included actually setting up the mental health care plan for one district very near to Bhopal called Sihor, and then integrating mental health care into primary care, trying to figure out models to do that through a couple of projects. We have also been working with the state to try to take some of that to scale across the state, and to also have done innovations locally, which we have developed and then implemented, published around developing digital trainings for psychosocial care for frontline health workers, and have also conducted large RCTs working with the health system. We also have an overarching MOU with the National Health Systems Resource Center, the Department of Health and Family Welfare, Government of MP. And more recently, we've also started working in the health equity space, especially working with queer trans communities, persons with disability, to try to again develop our understanding of what needs to be done in terms of providing better quality and accessible, affordable, and affirmative care for these communities. Now, we have a range of partners and collaborators, some of who I already spoke about, and it's with their guidance, cooperation, and collaboration that a lot of learning happens. And this includes both national partners, collaborators, as well as international partners and collaborators. Now, in terms of setting the context specifically for the topic today, we all know that it's been almost 45 years since the landmark Alma-Ata Declaration. This year will be the 46th anniversary. And as you all know, one of the things which happened at Alma-Ata was the identification of primary healthcare as being key to the attainment of both the goal for health for all. And uh, more recently, we've started seeing this discussion again become more intensive in India, and there's been this whole conversation around comprehensive primary healthcare reforms. So you have had all of these new initiatives under Ayushman Bharat, where the health and wellness centers, now called the Arogya Mandirs, were developed. The cadre of CHOs was raised, and then a whole lot of new interventions and packaging of services was done. And this is important also in the context of, as we remember, the definition of health, which WHO came up with as being one of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. And so, if within the definition itself, mental health and well-being is so intricately embedded, it's important for us to then talk about what needs to be done to ensure that it is actually available. And this is also important because all of us talk about universal health and universal health care and coverage. But we need to understand, of course, that you cannot get to the goal of universal health coverage without addressing mental health as an important component. And the fact that poor mental health by itself, it puts a lot of individuals and communities at risk of other priorities in global health, such as HIV/AIDS, such as NCDs, and worsens their outcomes. And there is a lot of linkages and evidence towards that, which clearly shows the interlinkage of mental health with poverty, with marginalization, with social ostracization, with stigma, etc. And in fact, among some population subgroups, such as young people, mental health problems could be among the leading cause of death and disability and morbidity. And during the pandemic, as we know, this was also something which was quite prominent. Now, one way of addressing that, of course, is also looking at how this fits in with the SDGs, because a lot of countries look up to the SDGs as important goals, and we know that mental health, directly or indirectly, is mentioned in various ways in multiple SDGs. You have the target 3.4, which specifically talks about promotion of mental health and well-being, and reducing premature mortality from NCDs through prevention and treatment. target 3.5, which talks about prevention and treatment of substance use, and target 3.8, which talks about universal health coverage, including financial risk protection, access to essential health services, affordable, accessible, quality medication, all of which also are linked again to mental health. Now, why mental health, right? Now, the reason for that, of course, is that global data indicates that almost 1 in 4 individuals at some point of time in their lifetime will be having a mental health or a substance use disorder. Almost 20% of global burden of disease is constituted by mental and substance use disorders. And this is a larger proportion as compared to cancer or cardiovascular ailments. But of course, it doesn't get as much attention. And almost data indicates from our own surveys in India, national surveys, that there is a significant gap in terms of access to mental health care system for almost 70 to 90% of our population, which of course means that it's difficult for these disorders to be identified early enough, linked to care, follow up to happen. So it also, a lot of this burden ends up being hidden. And in terms of even the costing of this, you will see that the estimates indicate almost that US dollars 16 trillion is just the cost of untreated depression. Leave aside other mental health ailments, and almost 80% of people who need mental health services globally lack access to these to quality care. In fact, in India, our National Mental Health Survey of 2016 indicated that only about less than 10% of India's population living with depression have access to evidence-based mental health interventions, which means that in other words, that the treatment gap is almost 80 to 90%. Almost 8 to 9 individuals with some forms of mental health conditions are not able to get care on time, which is of quality, and that is something which is a huge gap that we need to talk about. And part of the challenge, of course, is that a lot of care which is available is perhaps skewed. It is largely given by specialists such as psychiatrists and psychologists, but these psychiatrists and psychologists are relatively fewer in number. They are largely only in urban spaces, and most of them might be in the private sector, which means that financial access of care and the cost involved is also a gap and a challenge, right? And evidence-based psychological treatments have been developed, and a lot of this has happened in India as well with randomized control trials, etc. They've been shown to be effective as well as cost-effective. And this is something which can be delivered not necessarily only by a specialist, but even by a community health worker. But not a lot of uptake has happened so far. And that is partly something that we need to talk about. Just in India specifically, almost 200 million Indians suffer from mental health disorders. As per this Lancet Global Health Study, the contribution of mental health disorders to total DALYs has increased over the last few decades from almost 2.5% to almost 5%. Mental health disorders were the leading cause of years lived with disabilities, contributing to almost 15% of years lived with disabilities in 2017. Again, data from various sources, which reinforces some of the importance of bringing attention to mental health. So again, as we highlighted, there is a shortage of trained mental health workforce. Mental health services are often not available in community settings. They're usually only available in, let's say, a district hospital, in a medical college, in a private clinic, in an urban area. But these services in the private sector can be expensive. They are often only in urban areas because there is a need for chronic care. The cost of taking treatment also keeps piling on, and that becomes a barrier for many patients. And of course, another important part is that there is a lot of stigma and discrimination around mental health. People are scared to even get screened for mental health conditions because they are afraid of being labeled as having a mental health condition, right? And this is, of course, something which is influenced by public perception of mental illness, about our media's sort of hyping around mental illnesses, about what we see in movies, and the kind of labels which go around, for example, pagal hona, and what impact that has on individuals in terms of their own thinking about mental health. So it's very difficult sometimes even within our own families, to have conversations around mental health, and that by itself is a challenge as well. Now, of course, there has been a lot of work in trying to understand where is it that we need to hence focus some of our critical thinking around responses. And if you look at WHO's organizational pyramid for optimal mix of services for mental health, you'll see that there is a lot of possibilities, right? You could invest in long stay facilities, you invest in hospitals, both secondary and tertiary. You could invest in self-care, you could invest in informal community care. But if you try to look at the frequency of need, the cost efficiency of certain interventions, the quantity of services needed, you will find almost that primary care services and sort of embedding mental health into that might give us the most value. And hence, we should all think of ways in which we can bring about more mental health inclusion in this area. And this is what we need to strengthen in a way. Now, this is again in the context where there is an acute shortage, as we already discussed, with less than 1 per 100,000 population of specialists, stigma, prejudice, and this reliance right now in our health system on specialist care. And also the fact that while there are a lot of evidence-based developments, innovations, policymakers might not necessarily look at that evidence to make decisions. And that by itself also means that there is a barrier to good quality services which are accessible, affordable, and available, could be available closer to communities. And I think there's been now enough data which talks about the fact that there is a certain urgency pre-COVID, during COVID, post-COVID also. There's enough studies showing the importance of the need for investing in mental health. In this case, also a study which ICMR did, which talked about why this is important. Now, sort of looking at mental health in primary care is not a new topic. As I said, it's been referenced all the way from the WHO's definition of health development to Alberta to work which has happened in India as well. You know, this was a paper on the left side from Nimhans from 1987, which talked about evaluating some of their own work in this space. Then there's been work done relatively more recently at the village level, trying to evaluate what they have done to bring about mental health into primary care at a community level. So, you know, there's a range of things which people have tried out. And it's not the case that nothing has been done, right? But perhaps we need to do more. And there's also work done at the global level, the WHO MHGAP manual. The program by itself is a good reference document to look at, where WHO tried to identify what is it that we need to do in the space of mental, neurological, and substance use disorders, MNS disorders as they are commonly called, especially in LMICs. What are the kind of priority conditions that we need to address? And for them, they've sort of cataloged it as depression, schizophrenia, other psychotic disorders, suicides, epilepsy, dementia, disorders due to alcohol, disorders due to illicit drugs, as well as mental health disorders in children. So these are the kind of priority conditions that they talk about. And they also speak to the fact that if you want to really scale up responses to these, it needs to be done collectively by governments, by health professionals, by civil society, by communities and families, with support from the international community. And that is where I think all of us have a role to play. Now, if you look at the Ayushman Bharat scheme specifically, and if you look at the operational guidelines under that, you will see that within the guidelines for CPHC, there is an expanded box of services, the range of services, as we all know. And specifically, there is this whole section on MNS, right? Screening and basic management of mental health ailments. And this is relatively a newer edition since CPHC has come in, and perhaps also has not received as much attention in terms of the implementation of CPHC. But again, there is a need to do more. Though recently, one has to say that with the launch of Telemanas recently, over the last couple of years, and more investments in that space, there's at least more awareness of services and some more services being available through the tele route. Now, in the specific guidelines also, you will see that there is a mention of what needs to be done at the periphery in a health and wellness center. So they specifically talk about screening and basic management of mental health ailments, screening tools being used, community awareness being there, identification and referral to the health and wellness center or PHC for diagnosis, ensuring treatment compliance, home-based care, facilitating transport for to support groups, etc. And also talking about what kind of care would be available specifically at the health and wellness center in terms of detection, confirmation and referral, dispensing of medication, counseling being available, management of gender-based violence and other forms of violence and their implications on mental health, as well as what needs to be then referred up the chain in terms of anything which needs further diagnosis and treatment, anything which requires inpatient services, counseling services which might require a more comprehensive approach, which cannot be provided, let's say, at a health and wellness center. So enough level of detail already, but the challenge, as always, is taking something from a manual or a guideline into actually doing something on the ground. And specifically, also speaking about what kind of screening methods need to be there in comprehensive primary healthcare. So screening tools which involve questionnaire algorithms, etc., have been spoken about specifically in the guidelines. Now, in our work in Sangath, also we've been trying to discuss this with policymakers at the state level, at the national level, and we've tried to understand what is it that is possible and feasible to do. This is one example of a state level consultation where we did in Bhopal last year, where we invited a cross range of policymakers from various departments to try to see what we can learn. And of course, we've also been doing a lot of research in this space. This is just a snapshot of some of the studies that we have conducted in comprehensive primary healthcare and sort of looking at mental health, how it fits in, the role of innovations, working with community health workers, looking at digital interventions, etc. And then based on that, we've tried to make some learning and try to implement it. So, as I said, there is an issue, the issue of mental health being a priority area of investment. The fact that mental health right now is not available to a large section of our population, the fact that there is a major treatment gap, the fact that mental health is largely delivered by specialists, but specialists are in short supply, the fact that there has been now a development of a whole evidence base which indicates that providing psychosocial care could be very effective, but it is not available right now at scale, points us to the need to think about what we can do differently. And one area is certainly looking at psychosocial interventions. Psychosocial interventions which involve using an evidence-based counseling, using mechanisms such as behavioral activation, have been found by evidence to be quite effective for many mental health conditions. For example, PTSD, autism, anxiety disorders, where there might be even a choice, let's say depression, where you might be able to give a psychological treatment and you might have a choice of using medication, antidepressants. It's been found sometimes that psychological treatments might actually have better longer term outcomes with lower relapse rates. And even using psychosocial care in addition to pharmacotherapy or antidepressants actually has been shown to enhance the effectiveness of pharmacotherapy. So that's another reason to think about psychosocial care as an important component. Now, part of what we have developed within Sangath and with also similar organizations in this space is this concept of task sharing, where essentially what you do is move some specific tasks from highly qualified health workers to health workers who are more community-based, who have shorter training and fewer qualifications in trying to make more efficient use of the available human resources for health. So what you're doing is taking some levels of tasks within healthcare provision from specialists to non-specialist health workers, community health workers, and supporting them to be able to deliver that at scale and hoping that this will mean that more communities will have access to those interventions. And of course, there is a history to this. This has also been done in maternal, neonatal, and child health. All of you will know the Gadchiroli model, the home-based neonatal care model, where again the idea was to take neonatal care from an earlier model, which was neonatal in nature and focused on specialists who are available at, let's say, a sick neonatal care unit at SNCU, to also thinking about the alternate, which is more home-based, which was developed in Gadchiroli by Search, and then looking at that as a way of being able to bring down neonatal morbidity and mortality, right? So it's not that task sharing has not been done in other areas or thought about. Certainly examples exist from other areas as well. And so many of our projects have tried to then dig deeper into this. One of the flagship projects in Bhopal's in the Bhopal hub was a project called Essence, which we did for almost 5-6 years. In fact, this year is an extension year where we are going to finish later in this year. And what we try to do here was to try to find out the feasibility and acceptability of training ASHAs specifically to deliver psychosocial care for depression, and also try to find out if it would be acceptable for them to be trained digitally, because training a lot of individuals in person also requires a lot of resources and time, and that can be challenging. But with the advent of digital modalities, which have also picked up pace during the pandemic and post-pandemic as we do, is it possible to train many ASHA workers digitally and then support them in delivering psychosocial care to individuals with depression? And also then try to look at what are the other kind of allied things that we need to do in the advocacy space, in the policymaker engagement space, in terms of sensitizing media on reporting, in terms of working with service users and caregivers to provide support to them to be able to advocate for better quality care. And so the Essence project, which was funded by the US National Institutes of Mental Health, already showed in its implementation the feasibility and acceptability of digital training for delivering psychosocial care by ASHAs. And then we will have data coming out later this year, which will also show whether they can, what is uh, how comparable are competency outcomes in individuals who have been trained digitally versus regular face-to-face intervention training programs. Uh, Building on Essence, what we've thought about is what do we need to do more to be able to take psychosocial care more closer to communities. And this is where the collaborative model in primary care is something that we have been developing. It's called the Empower model. This is also being implemented in many other parts of the world, including work being led by Professor Vikram Patel, who is the global lead for Empower. And what Empower basically does is, one, of course, focuses on task sharing, where you choose evidence-based psychological interventions which is suitable to delivery by a non-specialist health provider. You digitalize it so that it is available to be imbibed, absorbed, taken by health workers at scale. You also ensure that you have some level of competencies developed so that you can again evaluate someone who's undergone a training to see if they're competent now to start delivering care. And this is then delivered at scale in a large community of health workers. And you also have a strong supervision system built in so that people who are trained are starting to deliver care are supported, and there is a way to ensure that the fidelity to therapy, the quality of care is being supervised. And some of this is also done at a peer-to-peer level. That's called peer supervision, right? And so this is what is broadly the global Empower model, which is a digital solution for learning, mastering, and delivering high quality assured psychosocial interventions. Now, for that, of course, we do use a lot of digital tools because these have the potential to accelerate progress and to lead to better mental health outcomes. Some of this, of course, is still being evaluated, but our preliminary experiences show that a lot of frontline health workers now are very adept at using technology. If we orient them, support them, train them, then they're able to pick up skills very quickly in terms of being able to learn from digital sources. Of course, you also need to support in terms of figuring out the need for internet support, in terms of data access, etc. But broadly, they seem to now be getting more and more comfortable with technology. And so under Empower, what we do hence is, as I said earlier, select an evidence-based intervention, digitize it, implement it at scale by training non-specialist providers, and then ensure that therapy is being provided once they're delivering it through, and this is being audited, provided oversight by supervision processes, both by experts as well as peers. And this is hence what the Empower model is. And as you will see in our work, at least in MP, in now many districts, we've started to see that many ASHAs are picking up the skills. We have also started working with other cadres such as CHOs. And so it is possible. Of course, you need to do a lot of hand-holding and supporting, and also there is always a challenge of time because ASHAs also have a whole lot of other responsibilities. But we have now worked with several ASHA supervisors and seen them learn various forms of psychological care, psychosocial care, including for depression, including specifically for perinatal depression. And as long as you ensure that there are systems to support them, it will be possible for them to be able to do it, but it will require support from the health systems as well. Because you could train them and they will start delivering some care, but if the health system does not recognize the delivery of psychosocial care as one of the activities which are core activities for ASHAs, then of course it is difficult to sustain that. So that is part of what we need to think about in terms of change. And actually, some of this work has also happened in Gujarat. We had a project where we worked with Argusoft, which many of you will know also was a technical partner for IMTECO. We worked with Seva Rural. We worked with the Hospital for Mental Health in Ahmedabad, and we did a small pilot in Jhagadia with both Ashas and CHOs, and showed again that this is also something which is acceptable, feasible in the Gujarat context, and we will be publishing that study data as well soon. So, of course, it's not just enough to train and do supportive supervision, including peer supervision. We also need to build a referral pathway, referral to the CHO, referral to the district mental health program, to the district hospitals, to hospitals in other jurisdictions, especially tertiary care hospitals. So, in our case, a lot of work is happening around Bhopal. So, referral to hospitals in Bhopal is part of the model. And for that, we train also newer cadres, as I spoke about, like community health workers, because it is part of their care package. You know, the 12 care packages that they have in health and wellness centers, which they're supposed to supervise and lead. One of them is, of course, focusing on mental and neurological conditions. And so providing refreshers to them, supporting them so that they understand what can be done in this space and what kind of leadership they can take on for that purpose. Now, part of what we need to talk about is also what we need to do at the community level, because as I said earlier, part of the challenge is that there is a lot of fear about mental health, there is a lot of stigma around mental health. So opening up conversations around mental health becomes extremely important. So what we try to also do is hence do events, activities, conversations, discussions at the community level. So we adapted the snake and ladder game, which all of you would have played as young children, which is quite popular in communities, to focus on mental health and conversations around mental health. And so we get a small group from the community together, you play this game, it helps you start discussing around why mental health, how mental health impacts all of us, what do we need to do to be able to address the need for mental health, etc. Right? So those kind of again small discussion fora can be created, and also doing a lot of discussion with communities. In this case, for example, this is a public engagement activity we did in a tribal block of Raisen district, where again we brought together this community which hails from a tribal region in the block and talked to them about why mental health, how it is relevant to them, and also with a lot of changes happening now with substance use becoming a cause for concern, with gender-based violence increasing in some communities. I think the role of mental health also becomes more and more important. And so, this is just an example of an activity which happened earlier today, which our team shared a photo of. So I thought I'll also show you that there are various ways of doing this, and you can involve young women, you can involve adults and girls, you can involve older girls in the community, older women in the community to be able to talk mental health. Now, a key demographic that needs to be engaged is, of course, the demographic of youth and adolescents. As I said earlier, there has been a lot of evidence which indicates issues around morbidity, sometimes also mortality in this group, which has a linkage to mental health. So we need to find ways where we can create safe spaces for these individuals to be able to speak about their concerns, about their challenges. And so we did a couple of events where we've done open mics at cafes with young people to try to encourage them to talk about mental health and their own struggles, etc. So based on all of this work that we are doing, let me give you a few recommendations around what we could do, right? Because I think you might be wondering, okay, all of this is nice to hear about, but what needs to be done on the ground, right? One, of course, important element is if we can develop and implement a minimum package of interventions in areas of mental health promotion, care, and rehab, which links all the way from primary healthcare settings to tertiary care settings. Now, some of that is already there in the CPHC guidelines, but we really need to figure out what is working, what is not working, what other interventions need to be brought in, what needs to be taken out, so that operationalization part becomes important. We need to also think of mental health as some form of a cross-cutting thematic area. So not just seen as a health issue, but also something which impacts education, social welfare, urban and rural development, transport, etc., etc. Right? We also need to think about how can we integrate mental mental health into programs such as NCD prevention and control, child health, adolescent health, geriatric health, TB, HIV, right? Any form of services, because mental health, just like gender, is something which needs to be cross-integrated. And how can we look at approaches such as task sharing to build further work in this area so that we can bring more care closer to communities? And this work, of course, has now been going on for a few years. We've received some appreciation and support from district level authorities. They've come to our meetings. They've sometimes talked about their own struggles with mental health, or that or those of their family members, and highlighted the need to work in this space. And as we again do these conversations at multiple levels, all the way from community to policy circles, hopefully it will mean that there is more acceptance around mental health. Now, in terms of things which still need to be figured out, one is, of course, what are the various kinds of mechanisms? I talked about a couple of experiments we've done in this space, but what else can we do to build the capacity of primary healthcare providers to deliver mental health care? Because if you go and speak to medical officers in many frontline facilities, they usually do not, screen for, diagnose, or provide care for mental health conditions. They like to just refer individuals up, right? They will not even do a first level assessment. Maybe they're not comfortable, maybe they're not trained, maybe they don't feel supported. So what do we need to do to ensure that people are taken care of as close to where they live as possible? Not every person with a mental health issue needs to be referred up, right? Because many of them will not go. And so you lose a lot of people in that. So if we can try to manage most at the community level, then we can maybe only refer those individuals who need true referral. How can we address issues around stigma and prejudice against people who are suffering from mental health issues? This whole importance, the importance of also working at community levels in terms of conversations around it, mental health specifically. And what do we do to bring about intersectoral collaborations? Because, as I again said earlier, mental health is not just something that we need to think of from a health lens, but also think of other areas of society and development, which is important. So we have this sets of challenges around poor access and unavailability of mental health services. We have a lack of competency of medical doctors, of nurses, of paramedical staff, of frontline staff. We need to build competencies of frontline health staff to be able to provide responses. You have an opportunity in task sharing interventions which can help overcome some of this. You need to ensure that medical officers feel supported to be able to provide medical care for mental health wherever they are posted. And we need to develop programs of training, credentialing, and supervising frontline health workers so that they can also start delivering psychosocial care, which is evidence-based. So, pulling it all together, I would urge us to think that integrating mental health into primary care is not an illusion. It is something which is possible to do. It is something which is essential to do. It is important from an inclusion perspective. It is an inherent element of health and well-being. This is also because mental health problems are very common. They are often hidden, but if you look at the evidence, it clearly indicates that this is a significant cause for morbidity and sometimes mortality. And there is also a lot of multi-morbidity where mental health is involved with other disorders. Some of these disorders also have an early onset in life, around childhood or early adolescence. And if they are not managed, screened, managed and on time, then this can actually become more and more complicated and lead to longer term poor outcomes. So it's important to try to do this. It's important to look at stigma and discrimination. And this needs to be done with an approach which integrates equity so that those individuals with mental health conditions are able to access quality care. It has to be done with a rights-based approach because there have been issues in this country, for example, where people with severe mental disorders, as we know, have been chained to beds. The Irwadi tragedy is something which many of you would have heard of, where individuals who were chained to a bed in treatment center, which was, of course, unregistered facility. Unfortunately, many of them were burned to death when a fire broke out. The need for evidence-based practices, because anyone can claim to be providing counseling, but is it based in evidence? Is it based in a particular science is important. This needs to be provided across the life course, not just at a particular time in life, but across the life course. It needs a multi-sectoral approach where various departments, ministries, stakeholders are coming together. And of course, we need to do it from a perspective that people with lived experience of mental health, either users of services or caregivers, also need to be brought into the center in terms of the conversations to understand their needs and the kind of responses which need to be built in. So thank you for your attention. Hopefully that would have convinced you to some extent about why mental health is important, why mental health in primary care is important, given you a snapshot of some of the work which has been happening in this space, including by Sangath, and also given you some ideas around what else we can do as a collective public health community to further work in this space. So thank you also to with the acknowledgements to my colleagues in the Sangath Bhopal Hub, to all our study participants, collaborators, community health workers, and funders who helped us do a lot of this work and helped us with our understanding, to colleagues who have helped with the presentation. And of course, you can also reach out to me via email. I'm also on Twitter and LinkedIn for those who would like to connect. And thank you again, Professor Sanjay, for the opportunity to talk today. So back to you for any questions and discussions.
Thank you so much, sir. Now the session is open for question and answer. So kindly raise your hand, or you can write in the chat box as well. Any questions from participants? You can unmute yourself, or yeah, Trupti ma'am. Trupti Desai madam. Yeah.
Good evening, Sanjay sir, and good evening, Dr. Anant. This is Trupti Desai from Shraddha Foundation. We are an NGO working in Vadodara, Gujarat. I'm also a mental health professional. My question to you is, sir, what can we do for adolescent mental health? Because adolescence is the age where many of the mental health problems starts, as we know. So to tap that uh, as part of prevention, what can we do at primary healthcare level for adolescent mental health?
Thank you, Trupti. Good to see you here as well. Trupti and I have been in touch off and on, and hopefully I'll get to meet Trupti in person sometime soon also. I know she's doing some really interesting work. So you're absolutely right. As I was referring earlier also, there is a lot of history of early onset of mental health conditions. And if we don't address that, because there are a lot of societal factors, sociological factors, which can also be predictors of mental health issues. Hence, it's important to think about what we can do with that. You have a whole approach which can focus on school, right? So you have school mental health programs, mental health and well-being programs, which are focused on adolescents, where you make them aware about their own mental health and well-being, where you try to make them, do screening programs, support those who need support in a way that it is done in a non-judgmental way, non-stigmatizing way, because as we know, stigma is a major issue which people are scared of, and hence they are not willing to speak out. We also need to figure out what is feasible to be done in our settings. There are also a lot of adolescents who are out of school, right? And how do we reach to that population? What can be the role of community-based organizations? What can be the role of outreach services from the health system in being able to work with these adolescents, especially adolescents who might be at risk, who are in difficult family situations, who are orphans, who are struggling with some kind of pressures, who are struggling with identity, right? So all of those individuals might need support, and hence having programs which understand these needs, focus on that, and provide responses will hopefully mean that many of these individuals will be identified early, they will be supported, they will be provided appropriate treatment where needed, and we avoid a situation where something which has just started off as a condition flares up later as they become older adolescents or in early adulthood and leads to a poor or adverse outcome, which is unfortunately what happens in a large proportion of cases. So I think that's where the role of all of us, especially mental health professionals and organizations which are working in the community space, working with governments, becomes important. Also the role of programs such as RBSK, RKSK, because there are counselors available who regularly visit schools. So how can we involve them? What can we do around public perceptions? A lot of adolescents now are on social media, and social media has its own level of stressors where people are sometimes also put pressure on. There is peer pressure around stereotypes, etc. And so what we can do to ensure that there is safer consumption of media and social media so that the stressors decrease. All of those are things we can think of.
Thank you, sir. My another question is, since you discussed in detail about training or skill building for community health workers, so how was the response of policymakers towards skill building? Because as we all are aware, that ASHA workers are already having overburdened for different work. So introducing this extra work, how has the policymakers taken it in positive way or in a negative way? Whether they were helpful to you for
Yeah,
skilling?
that's a very good question. And it's been a little bit of a mixed bag. Earlier when we started off in our SN study, we had first thought of working with ASHAs, but also ANMs and also multipurpose workers, right? Three different cadres. But in our formative work, when we discussed this with policymakers, one told us that multipurpose workers are probably not a cadre you want to work with because that's a cadre which is slowly dying off, right? We're not recruiting any new multipurpose workers. Most of them are older and are about to retire. ANMs, they said, are already very busy with maternal and child health, especially in the facility level. So they said, okay, let's try out ASHAs, let's see how it goes. And then, based on what you find out, we can discuss more. So that's how we ended up doing a lot of work with ASHAs in MP. But there are certain states which will say, no, ASHAs is not the right cadre for us. Our interest is more in working with CHOs because CHOs already have a base level medical training. They're either nurses or they're Ayush medical officers who are being further trained through a program, as you know. And so they are the right or appropriate group to offer mental health care at the community level. So it will very much depend on what the policymakers of that state think. But our programs are designed to be agnostic of that, in the sense that any community level member, whether that be a frontline health worker, whether that be a slightly more well qualified health professional, should be able to learn these skills because they have to be taught in a particular way and there has to be a standardized approach to ensuring that they are getting the skills, they are evaluated for that, and then they are supported when they are delivering care. So that range of what is possible is something which can be like a bouquet or a basket of choice, which is available to states. But it is important for them to think about it because, if they will get ASHAs to do screening for communicable disease, if they are also involved in non-communicable disease programs, then mental health is also something that they should think of. In fact, training frontline health workers to do good quality psychosocial care might make them better counselors also. And all of the other things that they do, including maternal and child health, the fact that they have these skills will perhaps make them a more effective person who is delivering care and supporting communities. So, but it is a difficult sell because, of course, many of these cadres are also incentive based. So, unless we build in an incentive component, then ASHAs might not be able to sustain this kind of work beyond the project period. And that's why the conversations around ensuring that there is support available, time available is important. So hopefully, when there is more acceptance of mental health happening, this will also be something which gets picked up.
Okay. Thank you, sir. Thank you very much.
Any more question from any participant, please? Thank you, Trupti ma'am. Any questions? Sir, yes, Sanjay Kumar ji, please. Suraj Kumar ji, please. Any questions?
Good evening, sir. I am Suraj Kumar Mandal and I am from NGO sector called Shiksha Dwar. And I have a question, like I am working with the student, primary school student or secondary level school students. So whenever I go to teach them or guide them, I face a problem like their mental health. Like some of the students are not able to understand whatever I am telling them. So how I could manage those students?
Good point. I think, we've also learned the conversations need to be sometimes simplified. Often we might end up using technical language. So, as I said, some of our work with communities involves just open conversations around mental health, why mental health is important, how mental health impacts everyone, playing games, or having activities where people have a chance to reflect. And it's through that organically people start talking about some stressors, about not feeling like themselves, about perhaps themselves identifying as having some of the symptoms of common mental disorders such as depression, etc. So maybe what we need to do hence is to think about who our audience is and what would appeal to them. So a lot of work happens in Sangath by many colleagues who work in a young, youth mental health group, and they have developed mechanisms such as websites where there is sharing of lived experiences by young people, where there are blogs, videos, stories, narratives, and sometimes people are more comfortable looking up to those kinds of resources, imbibing that, and then responding to those. They might not be as comfortable talking to each other or talking to someone. So we need to maybe also figure out within a particular audience, such as young people, what is it that is likely going to engage them in these conversations, and maybe build on that. So maybe you can also think about what is it that we can do with young people differently in a way that they might be more interested in having that conversation, and that might actually create a pathway for the kind of engagement that you want. And maybe speaking to other colleagues in this space might be useful, some of whom might be also on this call, like Trupti, who works in this domain as well. How do you work with young people and encourage conversations around mental health? I know it's not easy, but I think it is possible to do it, but it has to be done in a way that the audience sort of relates, because if we just take a lot of content to them, they might not be very interested. But when we make it relevant to them, when they recognize that this is something which is happening with us, with our friends, with our peers, then maybe those conversations will be easier.
Thank you, sir. I would like to implement these things. Thank you.
Any question from any participants? Anyone would like to ask any question? Sir, I have like one questions. Especially I particularly feel that in a higher education domain, mostly with respect to university or with respect to the affiliated college called higher education institution. I think, sir, we are completely missing the systematic, the support of, the ongoing current time. So, do you feel that, all the higher education institute, they need to recruit, the either the counselor or I mean, clinician from the psychological background, because stress or especially the mental health, and it lead from the, the stress, and they are not able to manage it, and it's so what do you feel, sir? Because when we are dealing with the youngsters, especially in the higher education, they also have a, this the habit of, they forgot, lot many things. They are not well. I mean, they also feel some. They have their own issues, and they are not feel well to share all the things. And I think uh, we see that it is not appropriately established the the setup where the student get some guidance, or even the school level. So there is no compulsion. But what do you feel? Do we have some rules or something like that to address such kind of the issues uh, from the beginning level, sir?
Yeah, I think it is important, and this is something which has also come up in the context of coaching classes. You will know all of the discussion around quota and some of the unfortunate outcomes which have happened with young people there. It's come up in the context of higher education institutions, and there is a lot of interplay of factors here, right? It's what kind of stressors are there, what kind of peer pressures are there, expectations are there, adjustment issues are there, relationship issues could be there. And we also have to recognize the intersectionality of issues, discrimination, which could be, for example, caste based or other forms of discrimination also have a role to play. So I think all of those are important to think about. Some institutions have tried certainly looking at hiring mental health professionals, as you said, for example, psychologists. Some of them have tried to create safe spaces like student wellness centers, which are drop-in centers where people can come in, have a conversation in a way that they don't necessarily feel that their confidentiality will be lost. Maybe it's a mix of things that we need to do. We need to create spaces where people feel comfortable to come and share their struggles. But we also need to look at the factors which are impacting their mental health. Why is it that certain individuals are struggling? What might be the pressures that they are undergoing? Is there discrimination happening against them? If we don't look at some of those larger social factors, then we are only doing a band-aid based approach, because we are trying to look at the downstream issues but not the upstream conditions or upstream issues which might be leading to the kind of outcomes which are happening. So maybe the combination of things needs to be there. But again, as I would say, that maybe it has to draw from evidence-based. It has to draw from a nuanced understanding of why these young people might be struggling, and what can we do to support them in a way that does not further stigmatize them, does not further make them uncomfortable, but supports them through a sometimes difficult journey of adjusting into a new environment and a new institution. So I think, again, a lot of work could be done in that space by all of us, by our institutions, by organizations working in this sector, and also by young people themselves. A lot of young people could support each other. In fact, a lot of good programs have tried to see how there can be peer support networks where young people offer support to each other in the mental health space. And that also has been shown to have certainly benefit in some programs.
Sir, I would like to add one thing here. Uh, uh, I was working in one of the universities, private universities in Jaipur, and I had set up a public mental health counseling center there in the university. So, in my experience, I found that when we are discussing about stressors, another factor that leads to stress of this adolescents and early adult children are undiagnosed neurodevelopmental disorders, actually. So this is a major issue because they find it very difficult to adjust in a university environment. In school, they could adjust somehow and they could complete their schooling, but then universities studies are very different, and they find it very difficult to cope up with that, and that creates a lot of stress in them. So I think that is another area where we need to address the issues, actually.
Yes, thanks, Trupti. Yeah, absolutely. I think, as I said, the issue around adjusting to a new environment, a new approach to learning, and all of the allied issues which come through can play a role. So that's why we need to be creative also, and figure out support mechanisms which will work in that domain, right? Not everything that, for example, as you're rightly saying, something which works in a school setting might not work in a college or a university setting. We need to adapt our interventions to that age group, to that those kinds of challenges which are there. Absolutely.
Yeah, any question from any participants? Any question from participants? Manoj ji, Kanchan ji, Nilesh sir, Dr. Pragnya, Paramita ji, Madan ji, if you have any questions, feel free to ask. I think, sir, one more, the observation related to mental health. That is, I think, still the superstitions are there. As you know that normally nowadays for normal, like if you have fever, if you have cold, you can go with OPD. But normally for mental health, we are not going, we are going with some other kind of traditional form of like temples and some well-known, there is specific places, religious places where there is the concern that if you pray for that particular god, so, or have some kind of offering or something like that, and you will be get a relief. So how do you, sir, analyze, on scientific way? Is there any relevant or, I mean, what is the reality, sir, based on your scientific practice, with this i- sensitive issue, sir?
Yeah, I think it's a good question and a good point. And as we all know, there's a whole range of cultural practices around mental health. It could be anywhere from, this patient ko bhoot chad gaya hai, to the need to go to a sort of religious site, going to a temple or a dargah for treatment. Now, those of us who work in the space of evidence-based practices, of course, will struggle with that. But there are some interesting programs which have tried to also combine an approach which allows for people to feel that they can go to, let's say, a religious place, but then encourage them also to receive evidence-based care, right? And so you have the Dawa Daru program in Gujarat, and similarly in MP, there's been an attempt to try to work with all of these places where faith-based care is provided in a way that people are identified, they are provided care, and they are referred, while not necessarily completely negating their uh, wanting to go to a venue where they feel that they feel better or they want to access care. So maybe that is one way of sensitively dealing with it, because some of these issues around faith can be sensitive, and so finding a way where you try to ensure that people are not at risk, they are not harmed, because anything which is harmful or where there is abuse happening or violence happening is something which is problematic. But also finding a way that we can link up in a way that those who with our having mental health conditions can be provided services, and evidence-based therapy would be a good idea. So maybe looking at some of these experiments in that domain would be useful. Though we also have to draw sometimes a hard line when we know that people are being provided uh, all kinds of things in the name of response, where we know that it is not evidence-based and there is exploitation happening or harm happening, then of course that is not acceptable. So that, I think, is important, but it's also important to try to think about how we can sensitively approach this with communities.
Yeah, sir, like very small questions. Is there any role, parents, especially in the case of student, any role of parents can play, just tips kind of thing. What parents need to perform, while nurturing their kids, especially in academia or anywhere. What do you feel? And is there any your bullet points for them, for the parents? Because most of the people may have in the role of parents.
Right.
I mean, are we generating any stress for our kids any way?
Absolutely, I think parents have a very important role to play in the upbringing of any child or adolescent, or sometimes even adults, right? Many of us who are adults also have parents, and sometimes we are ourselves parents while also having parents, right? So I think that interplay is always there. And as you rightly say, parenting is an important part of helping children grow into a world which can have its own stressors. So if parents can understand how they can deal with children in a sensitive, empathetic manner and be available, and create safe spaces at home, and spaces which allow for the child to express their vulnerabilities, to have open conversations, to sometimes say no, and say this is not an area of my interest. Don't push me into it. I don't want to do this. I would like to do something else, and be open to that, and not having kids feel that there is a whole lot of parental expectation and they don't have a choice. They have to abide because the parents are investing in them, spending a lot of money on them, want them to do certain things. and that creating some kind of a pressure cooker situation, and that causing, of course, sometimes unfortunate outcomes, or where there is a lack of communication, where there is a lot of perhaps a lack of space where kids can be open to their parents and have conversations, right? So parenting is a skill, and all of us can learn to do better. And there, part of this is, of course, creating a space at home where parents and children can have more open conversation and perhaps even support each other. I mean, maybe parents also at some point of time need the support of their children, in terms of, because parents are also not immune to some of these, and children are very perceptive, they can pick that on as well. But it's extremely important for this to be also something which is not just seen as a school activity or seen as a specialist activity or something which is only happening outside the home, but what kind of a environment we have at home also becomes important. You're absolutely right.
Madan, say please. Madan Singh, do you have any questions? We are not able to hear from you, Madan Singh. So, any question from any participants before we conclude the session? Anyone would like to ask any questions? Sir, do you feel the government has made an appropriate setup with respect to the mental health right now? Do you feel it is a sufficient infrastructure do we have as far as the treatment part is concerned?
I think certainly the government has invested. It's not to say that they have not, and there are, very good institutions like NIMHANS and similar institutions. But I think given the scale of our population, given the need in this country, a whole lot more needs to be done. And more public investment is needed, more investment by civil society is needed, more integration of mental health is needed because of the kind of importance of mental health as a cross-cutting issue. So what we are seeing is good, but it is inadequate. We certainly need to see more across both central government and state government, and not just at the level of creating capacity at the specialist level, but also looking at what we can do in the primary care level, which is what we discussed today in our session. So I think it was a good session to sort of speak to those issues, because otherwise, of course,
Yeah.
we can always keep discussing how many more courses for psychiatrists and psychologists do we need to create. But then, will that change things dramatically, and how long will that take versus what is possible to be done in our own communities is a good conversation to have. And maybe
Sir,
that's a good note to end our discussion also.
sir, one good things, that I particularly realize based on seeing the non-business of non-profit sector across the country. I think there are various varieties of programs are there, like they work for women empowerment, they work for disability sectors. But I particularly see that, I think mental health is not so far even touched by the civil society or voluntary sector as well. So, sir, would you like to suggest anything, if any, of non-profits, if they wanted to design any programs, especially for considering the mental health as a core aim? So, what would be, how they can start, with, from their own efforts, especially because I think it is not so far mainstreaming thing. If you say that women empowerment, you find lot many organization, but as far as the mental is concerned, we have very few. So, what is your message to them if they wanted to design any mental health programs or the what work into this sector, sir? Do you feel any opportunity or gap?
Absolutely. I think mental health is an intersectoral issue. Whatever area of work you do in health and development, you can always integrate mental health into that. In fact, that will only strengthen your program, whether you are working in women empowerment, whether you're working in infectious diseases, non-communicable diseases, provision of any form of services. If you're working in the space of education, if you're working on community health, in all of these areas, you could think of how mental health can be integrated. What can you do for your own workforce? What can you do for your community beneficiaries? How can you work with them to try to make mental health available, make them more accepting about mental health conditions? open up conversations around mental health, identify mechanisms where people can be screened and identified, put on treatment, referred to care. So they, all of us can start in some way or the other. If you're working, for example, in violence against women, then of course, gender-based violence and mental health is important. If you're working in maternal and child health, then perinatal mental health, and depression in pregnancy is an important area to focus on for the well-being of the mother, and also in terms of fetal outcomes, etc. So I think all of our areas, there is something about mental health which can be integrated and would have an important role to play. So in terms of opportunities, of course, you could figure out ways for your staff to get trained. You could learn. There are multiple programs available. Sangath does a few of them. NIMHANS runs programs, which are certificate programs, diploma programs. You can reach out to maybe organizations which are working in this sector, see what of those programs could be useful, and then maybe build on that and see what of that fits in well with your own program, and try to start small, but then build on that, and think of mental health as something which is a core programmatic issue which needs to be brought into all of your programming. And if we do that, maybe our programs will also be more comprehensive, wholesome for the communities that we work with.
Yeah, thank you, sir. Madan Singh, you can ask the questions now. Madan Singh?
I think Madan
Uh,
Singh ji has put it in the chat. I'm not sure if his microphone.
yes, Madan has put in chat box. You can read.
So I think Madan ji is asking an important question, which is around persons with severe mental disorders, and sometimes the fact that their families or caretakers might also face a lot of stress because of the long-term care requirements, right? And part of this is, of course, again linked to the stigma. The fact that a lot of these communities, families have to hide individuals or keep them indoors because they are concerned about public perceptions is part of where the stress comes from. Two, of course, we don't have very good community rehab programs because we moved away from earlier concept of institutionalization, right? We know of the past history of asylums in inverted commas, which is of course not very rights based. There's been some really good programs which show that community-based rehabilitation is possible. If people are put on treatment, if they're maintained on treatment, then many of them can lead relatively good quality lives, and their families can also, of course, help and be able to cope. But it requires us to have those programs being available and ensure that there is good mental health rehabilitation available. And the other important thing is the mental health and well-being of caregivers also needs attention, which is where, and especially in mental health, it's extremely important for us to also think not just about the patient or the service user, but also to think about the well-being and the mental health of caregivers. And so in mental health, a lot of focus now has been on thinking about the lived experience as encompassing both the person who is a patient or service user, but also the caregiver or caregivers, because it's important to think about the impact of mental illness on them also, in terms of the care they need to provide to the patient. And if we do that, perhaps we'll do a better job of this.
Thank you so much, sir, for your nice deliberations. Now, if any questions, any last questions that we have take up, then we conclude the session. Sir, as an individual or for as an organization like Sangath, are you able to mentor if any organization wanted to, if they have some concern or queries, or anyway, it is a professionally or personally?
Can certainly try and do that. And Sangath runs sometimes capacity building courses also, which are for individuals, but also organization representatives can apply and come. If any organization would be interested, then they can reach out to us and we will try and put them in touch with the relevant folks, or keep a lookout on our website for any training programs that we run. And if any of you is interested, you can also maybe then participate and learn more. There are many other organizations doing very good work in the mental health space, which might be around you. So look at them also as potential organizations which can support you, institutions as well, whichever state you are based in, which are also running regular training programs. Just by a way of example, in Ahmedabad, the Hospital for Mental Health runs a lot of good capacity building courses. They've been working with the state government training CHOs, training other health cadre. So, you could also look at those organizations to try and see what we can learn from them and what kind of programs you can introduce in your own work at your organization.
Yeah. Thank you so much, sir, for your time. And I think I personally believe that it is a very nice interaction or discussion that you share with us. You also, the answer the questions that we have asked or participant asked. So, dear participants, and with the permission of our honorable speaker, Dr. Anant Bhan sir, uh, just our attempt, at NCD is to have such kind of awareness, and I'm sure that this kind of conversation is also inspire people to have such kind of thoughts, especially some insight for their program as well as far as the mental health is concerned. So thank you so much for sensitizing our participants. And this session is also available live, and there may be other participant will also see these sessions, and it has a long impact as well. Thank you so much, sir, and thank you all participants for joining us. And with the permission of our speaker, would like to end the session over here. And I also share the feedback link. You can share your feedbacks uh, to the sessions for today's sessions. And if you want to learn anything, you can also write down in your feedback forms. Thank you, sir. Thank you all participants.
Thank you, everyone. Please take care. Namaskar.